Yeah, Wednesday, Thursday, so she's the Wednesday work for her.
Okay.
She was wondering if she
It
could.
was supposed to.
That'll work. Yeah.
It's not, I'm sure.
That was my big ass.
Toss a pin.
That's good.
Toss a pin down that way.
Time, chief.
Start that.
Sorry.
You just.
Okay. Morning, everyone. It is Monday, November 3rd. This is our regular staff meeting. We'll start off with our warrant review. Are there questions on page 1 of 1?
Mr. Chairman,
Yeah.
I just had a question for pavement markings, snowplow for Double Eagle. Is this for the upcoming winter?
Mr. Chairman.
Yeah.
It is, we prepay per month, and because the building hasn't been sold, this would be for the month of November.
Okay, so we're still working on selling of the building, but this is.
And then quarterly, we get the reimbursements, we split it with Compass.
Okay, thank you.
Other questions on page 1? Moving on to page 1 of 13. Are there questions? Page 2 of 13.
Mr. Chairman,
Yes.
I don't see the assessor here, but I wanted to ask him on the holiday in lodging for 2764 in Casper, just to give an update of what that particular, it looks like it was a conference, but I can't tell what it was. So I will reach out to him and see if I can get more information that way.
Okay. Other questions on page 2? Moving on to page 3. And 4. Page 5. Page 6.
Mr. Chairman,
Yes.
I was hoping also to have Eric here, just simply to get an idea. I see that we've spent $3,500 for your Norco, just to get an idea on how long that supply will last, but I'll reach out to him as well.
Mr. Chairman.
Yes.
The maintenance supervisor will be up for a while. They do 2 purchases.
Okay. So this is
So it's about
approximately for
6
6 months. Thank you. I just had questions on it.
Okay.
So,
Other questions on page 6? Moving on to page 7. And page 8. Page 9.
Mr. Chairman,
Yes.
under public health, I've got a lot of questions today. I apologize. Under MasterCard, Amazon tumblers, I was hoping someone could explain what that $140, what those tumblers were used for.
Mr. Chairman.
Yeah.
I do not have an answer, but Heidi's coming up to hopefully answer.
Heidi, manager at Public Health. I had the same question when I saw the charge on there. And so they were used to, we do some outreach at the college.
Mhm.
And it was the beginning of the semester, so we used those tumblers to hand that out.
Okay. Was that paid for through a grant? or-
So, and it was a funding opportunity that we received the funds through the state of Wyoming, the CDU in Cheyenne. And so that was about $1,400 that we received. We paid for it out of our general budget because that money goes back to the county and not back. But it was reimbursable through the state.
Okay. And I'll have a couple more questions when we
Okay.
get the grants, so.
Sure,
Thanks, Heidi.
thank you.
Other questions on page 9? Page 10 of 13? Page 11?
Okay, Mr. Chairman.
Yes.
I have 2 questions. One was, these are both under grants. One's for an Etsy trophy for $43, and then also another one for Job Form Incorporated Goldly Yearly Nonprofit. Just hoping to get some explanations.
Mr. Chair, we will have Ann talk first and then I.
Okay. And Perkins Prevention at CSBG. The JOD form is an annual computer program that we use for Bighorn County for community service block grants. So that comes out of the Bighorn County part of our budget. And the other one is not mine, so that one I'm not sure.
Okay, thank you.
Yes, Heidi.
So the trophy that was ordered was for employee recognition, and that's going to be reimbursed through the workforce grant that we have. That grant is to support our workforce and by whenever we see that we need to support our workforce. So that's going to be an internal thing that passes from employee to employee every month, just recognizing them for the things that they do.
Okay, so that workforce grant comes through the state.
Correct. Okay, thank you.
Thank you. Other questions on page 11?
Mr. Chairman?
Yeah.
I'm wondering what a rat cam is, Peak Tire Sports. I didn't get an explanation looking at the invoice.
Where are you looking at, Mister?
It's the third one down.
Under grants.
Yeah, Grant, MasterCard. The third one down, Peak Tire Sports.
Okay.
It stands for rat cam.
Mr. Chairman, I'm unaware of this one, so
Was it under mine?
it just says Grant MasterCard, so I don't even know unless I saw the.
I believe it is.
It is.
Yours.
Okay, thank you.
Inch and a half ratchet or something.
Yeah, that's what I'm.
That's what I was kind of thinking, I'm not sure.
Yes, this is Jesse with Emergency Management. Yeah, that was part of the donated funds that was to my office, and that was ratchet straps to hold down the ATV onto the trailer. So those were, yeah, the ratchet straps.
That makes perfect sense.
Yeah,
Yeah.
so got to hold it to the trailer somehow. So
Very good.
yeah, and like I said, those were those donated, part of those donated funds.
Very good. Thanks, Jesse. Other questions on page 11? Page 12. And totals on page 13. And the accounting from our Sheridan County Airport questions.
Mr. Chairman,
Yes.
I just have one question, on the first page, under, I think it's Breimer Industries. The way this is kind of set out makes it hard to tell, but, invoice for AOA signs for 517658. I was just hoping that airport manager could give us a little bit of, where that's at the airport, what they're working on, want to look at it.
Yeah, let me.
Oh, gotcha. Robert Gill, Sheridan County Airport Manager. So around our perimeter fence around the airport, about every 200 feet, we have airport property, no trespassing signs. So that's a substantial amount of signs. So we've kind of been phasing that in the last couple of years on getting the signs updated. They're about at least 20 years old and getting faded and weathered. But then we were also updating signage on all our electric gates, getting them renumbered. We have about a total of 21 walk-through gates too that we've been renumbering. And then also providing signage to contact airport maintenance if a sign is malfunctioning or broken too. There's got some tenants that they don't have that operations number, so we were getting that posted everywhere. So that's what both of those are. We're just getting our signage plan updated.
Okay, I appreciate that. I was just looking through it and those invoices, sometimes you can't tell.
Yeah.
You said rat straps.
Mm-hmm.
What is that?
Yeah.
So thank you. I appreciate the clarification.
Other questions on airport accounting? Seeing no other questions come up. We will move on to our staff and elected reports. Mark Reed, County Planner.
Thank you, Mr. Chairman. My name is Mark Reed, County Planner. So this is our busy week of the month for meetings. Obviously, you folks have a couple of Planning items, a couple of CUPs, the vet clinic, and then the proposed storage on Deep Creek. P and Z has 3 items this week, minor subdivision, CUP also for proposed Bighorn Rec Center. And then finally a rezone proposal for the Clearwater interests out on McCormick Road, just a little over 100 acres. So anyway, those items will be coming up. If you have any questions on them, please stop up and we can get you information ahead of time if you like. Construction permitting, we're slightly ahead of the past 2 years in terms of overall numbers and running about 87% of the peak year in 2022, the COVID peak, as I call it. We've had 88 total dwelling units permitted this year, so people keep moving into the county. It's like unabated. So anyway, that's all I've got. If you have any questions, let me know.
Questions for Mark, anybody? Thank you, sir.
Thank you.
Ken? Okay. Ida?
Mr. Chairman, thank you. Eva Shem Thompson, County Clerk and Recorder. Just wanted to update you on the Penrose Lane, County Road number 9. The resolution was recorded in the clerk's office on Friday, and the plat describing the legal description was recorded in the clerk's office back on October 22nd. Once that recording is finalized, we will move ahead and issue off of the resolution. We will be able to then pay per the resolution the amounts to be awarded, and I just wanted to remind you that awarded amount totaled $27,000, and damages will be awarded to Mr. Jonathan
Ludich?
Maludich in the amount of $18,500, and damages will be awarded to Dr. Margo Hannon and Mr. Scott Robinson together. They own the same property in the amount of $8,500. So we've been waiting to pay that per statute. It's either by an invoice or order of the board, and that just got recorded. So we'll be finishing that up shortly.
Very good.
And then an update on the additional retail liquor license. You'll be considering the notice tomorrow during your board meeting. The notice of intent to accept applications for 2 retail liquor licenses. And I just wondered if you had any questions, if after looking at that in your packet, if you had any questions either for myself or for Deputy County Attorney.
Straightforward to me.
The nice thing about this is we do have a GIS layer in our mapping server that shows where all these licenses are. And just something of note, Richard has updated that because, as you know, sometimes the names of the owner changes. The place may not, but sometimes they're transferred to new owners. With that update, he reminded me that with the annexation of the city of Sheridan, we're starting to see more of those retail liquor licenses fall within that 5-mile buffer. And statute states 3 can be in that, but as the city annexes further south, more of those are falling into that, and it's nothing we control, but that's why the notice says they must be outside of the incorporated area, that 5-mile incorporated area. So. And let's see. Department of Audit had sent you an email notice of special districts and cities and towns and counties that were still not compliant. And the ones listed for Sheridan were down to 1. predatory management district for Sheridan, and they did finally submit everything. So I'm hoping that soon the Department of Audit will recognize that and update their list. It's simply a click, which is really nice, to the state where you can go look on that email that they sent you, and they update those daily. So it's nice. We don't have to call or email to check that. So I'm hoping this last one will be compliant here soon. And I think that's it. Unless you have questions for me?
Questions for Ida? Ida, what were they doing that was not in the compliance? Was it like the minutes that weren't being submitted, or what was the issue?
No, it was the budgetary item, and the report was the F-32 report that they had not submitted yet.
Okay.
So it's really a nice list when you click on that link in your email. It's very specific, so it's very helpful, and it tells you a lot of other information as well.
Okay, thank you. Diana?
Diana Bennett, Sheridan County Attorney, just letting you know we've been looking at the stats in our office, and we've now hit about 20% increase in all of our, we've never had this many felonies in a year before, and about 20% overall increase in cases. So when you're hearing about this increase in people coming, moving here, we're certainly seeing it on our end. We've never had this many cases, this many felonies ever, and we still have 2 more months. So it's, I guess, good and bad. People are moving here, but so is crime.
So we're not getting the cream of the crop, is that what?
Well, we're getting them all, I guess. The involuntary commitments, and the claim can, not so much here. I don't know what the numbers are for those actually. But we've been getting people that are in other counties that are being billed to us because that's kind of, they're a resident of Sheridan and they're being committed somewhere else. We get the bill for that. It seems, when I got my little budget thing from Ida, we're in the red on that because other counties, but we have Sheridan residents getting titled in other counties. And then they're sending us the bills. So that's going on. And I think that's higher numbers than we've seen. So I'll let you know. Any questions?
Questions for Diana? Anybody?
Thanks.
Thank you. And nothing. Dr. Bird? No. Heidi, anything else?
No.
Jesse?
No, sir.
Kimber?
No, sir.
Okay. Robert?
Thank you, Mr. Chairman. Robert Gill, Sheridan County Airport Manager. Had a proposal opening last Thursday for a hangar for lease at 903 West Frontage Lane. That's referred to as the old AVCON building. As you're facing the terminal building, it's the hangar on the left. Did receive one proposal for that building from Bighorn Airways. So be moving through that process with the public hearing and then the recommendation on moving forward with the lease agreement. Later on this week, we do have a bid opening. This would be for the conversion of the old FedEx building, getting that converted back into a hangar. So we did go out for bids for that while our opening on Thursday, and then I'll be bringing forward a recommendation on that as well too here in the near future. Tomorrow on the agenda, I do have the consideration of the consent to the sublease agreement between Jake Spinoler and Wyoming Wheels and Deals. This is the car retail service that we were discussing last week. There's a little bit of conflicting information there with not withholding. It's stated within the lease agreement within Jake Spinoler that we won't withhold consent to sublease, but in the CC&Rs of the business park, we do have that we will not allow car lots, car sales lots, those type of items. CC&Rs looking into it, they can easily be amended to include the legacy park if we do want to go that route as well too. So, and then last item I had, I was looking to maybe more formally form the ad hoc committee to look at some of the leasing on the airport. We've discussed taking a deeper dive into some of the high-level items as far as reversionary clauses and terms and taking a harder look at some of those items. So I think in our last airport work session, we discussed maybe a couple of county commissioners, Clint. And I don't know if we want to pull in somebody from the public as well too. There's definitely some people have some pretty good knowledge on the airport and real estate as well.
Yeah, so Robert and I have chit-chatted about this a little bit, and so I would definitely be interested to join that group, and if anybody else on this board would like to jump in, that would be super.
Mr. Chairman?
Yeah.
I would be pleased as punch to join.
Please just punch.
Pleased as punch.
Okay,
And then I also think it would be helpful to have a couple of members of the public, maybe two.
Sure.
From maybe one that's got a little bit more information on the leasing and maybe one that's maybe not as involved, but is.
Yeah.
Yeah.
Okay.
That's my thoughts.
And I guess I don't know if we want to appoint these people now. One person I think that would be very valuable would be Bruce Garber with Century 21. He's got a lot of experience working some of the real estate deals that have taken place on the airport. He's a longtime pilot. He's familiar with aviation. I don't foresee there being a conflict of interest. I don't think that he's looking to construct anything on the airport, but he would be a person that I would recommend that he has some pretty solid insights.
very good. Robert, would you reach out to him, or have you already, or?
I haven't discussed it, so, but I can definitely reach out and see if it's something he would be interested in.
Yeah, sure, that'd be great. Anybody else want to jump in off this board? Yes, it's Holly and I.
I think it would require a little bit of thought as to if we wanted another community person. Never really thought about it.
Yeah.
Yeah.
Okay. Very good. Anybody got questions, comments? You'll ring.
I would just point out, just Robert and I are always examining our words. Use the word appoint. You can't appoint somebody who's other than sitting at this dais, so you can invite members of the community.
Maybe we can point at them, right? Anyway, Robert, if you would chit chat with Mr. Garber, that'd be great.
Okay.
And we will continue on from there.
Okay, sounds good. That's all I got. Thank you.
Sir. Kelly, do you have anything? Kenny? Levi? Clint? Cameron?
Mr. Chairman, Commissioners, I forwarded an email this morning from the Sheridan County Chamber of Commerce. They're going to be having their legislative committee forum on Friday, December the 19th. They're reaching out to the commissioners to see what time frame you would like to present to all the elected officials down at the state legislature. So you have an early morning, mid-morning, early afternoon, late afternoon. They're all about 2.5 hours. So you basically have to come up with someone who's going to present, maybe another person who's going, but I need to know a time frame today as to what our choice is.
Works for Lonnie, our chairman.
Early morning.
Early morning.
Yeah.
So if I can't get the early morning, I'll put the second choice as mid-morning. Is that fair?
Yep.
Okay. Thank you. I have nothing else unless you have questions for me.
Questions for Cameron? Yeah. Question? Oh, no, I'm sorry. I thought Rita did. Oh.
Mr. Chairman?
Yeah.
If, before the board reports, I do have one more item that I forgot. I apologize.
Okay. Go ahead.
If Mr. Duff is done.
I think he is.
Okay, my apologies. I had one more item hiding here. It's an update on the Rapid Creek Road vacation topic. And I just wanted to note that I did forward you the email from Mike Lansing, who's representing YO Edwards and Holy Cow Ranch. I did respond and I sent him the draft of the resolution that you'll be considering tomorrow. And you'll see his email that he's currently in Australia this week, visiting his son. He saw in shared media that the vacation to Rapid Creek Road is on the agenda for your Tuesday meeting. He wants you to know he will not be able to attend. Let's see, he wanted to know if there were any objections. I let him know there were none. Please notify the commissioners that the applicant's counsel is out of country or would be there to answer questions. He mentions reciprocal easements, and he said he would forward that to clarify the neighbor access. I have not seen that yet. But anyway, I just wanted to put that on the record that I did share that with you and made you aware.
Very good. Thank you for that. Mr. Jennings, do you have anything?
I don't have anything, thank you.
Mr. Rosie?
Oh, nothing this time.
Mr. Siddle?
I'll just be out from Wednesday afternoon, for a week. But I'll still answer emails, answer my phone, whatever, but I'll just be traveling for a week. Thank you.
Okay. Mr. Haswell?
No, sir.
I don't have anything to add. Moving on. We have an hospital information update. I would invite Mike Cafferty, CEO of the Sheridan Memorial Hospital, to come and inform us. Thank you.
Okay, is it on?
A little bit closer.
Well, thank you very much for the invitation. I want to take some time to give a little bit of background on this. I want to be very respectful of your time, so I'm very interested in how much time you think I have here. 15 minutes? 10?
Do you need?
60?
Now you're pushing.
I originally told him about 20, but whatever.
Okay,
Yeah,
that's
yeah.
good. I can do it. I can aim that 10 to 20 minutes. What I wanted to do is just kind of share with you some of the things that we've been working on. Of course, lately we've made an announcement about our intent to pursue partnership with Billings Clinic, and obviously that I'm sure is very interesting to all of you. Last year I came and gave a full presentation on some of the things that are challenges in rural healthcare, and don't expect you to remember all those things, and I don't want to take up all your time refreshing your memories, but over the last year we've been doing a lot of work trying to educate the community about what's happening in healthcare in general, what's happening in our region, and what's happening in Sheridan and the impact that that's having. And so I want to share a little bit about those kinds of things today. And I want to also kind of cut to the chase and get into the discussion around what is a partnership and what does that look like, and how does that concern all of us. And so that's kind of what I want to share today. I do want to let you know that we have been having conversations with our employees, with our medical staff over the last year. We've actually engaged in a lot of strategic planning around this. We have a lot of great ideas and support along the way. Over the past couple of weeks, I've been doing my best to get out to the community and share a full presentation and a plan around what we're doing or what we're contemplating. And just trying to get input from the community and allow for opportunity to ask questions and answer questions to the best of our ability. We have some more public meetings this week, and I continue to meet with our legislators and different folks, and just trying to provide as much information and education as we can around this so that people are well informed about what we're doing and what we're not doing. Okay. If you don't mind, I've got a couple of things here to pass out to the room. So what I'm providing you with is kind of an abbreviated PowerPoint of what I've been sharing with the community over the last year, and in particular over the last 2 weeks as it relates to what our path forward might be. And so I want to be, as I said, respectful of your time. And so I'm going to I'm going to run through a lot of these things pretty quickly so we can get to the meat of the matter that I think. Thank you so much. I appreciate it. So first of all, in terms of everything that we talk about, it's all about our mission. We exist in this community to take care of our families and our neighbors and our friends. That's why the hospital's here. Okay? We don't exist to enrich shareholders in any way. This hospital for this community exists to serve a mission. Okay? That's first and foremost. As we talk about that mission, there are some things that we need to be aware of around rural healthcare, what's happening in rural healthcare, what's happening around our geography, what our cost structure is. I think that's a very important discussion, especially for you guys to understand consumer perspectives, support to the community through our organization and through philanthropy, and then the affiliation model. So that's kind of those are the topics that I'm going to cover. I'm going to cover a few of them maybe more quickly than I would typically because I do go into some depth in these community presentations. So on that first slide, U.S. rural hospitals, 2.2 million women in 1,100 counties across the United States live in what's called a maternity desert, meaning that they have no access to obstetric care. They have no access to a birthing center, a nurse midwife, or a mid-level provider for obstetrics in their hospitals in their counties. That's a big deal. That's something that we don't recognize or maybe understand in Sheridan. We have 5 OBGYNs in Sheridan. We've made a huge investment in maternal care in Sheridan County. And that's a big deal. We have 5 OBGYNs and 3 mid-level providers taking care of this community. Okay, Evanston, Rollins, and Wheatland have dropped their obstetric care. Okay, and a lot of smaller communities don't have obstetric care. Okay, on the next page, you can see on the bottom right there, it says 50% of rural hospitals in the United States operating in the red last year. Okay, 50% of rural hospitals operating in the red. If you go to the left-hand chart, you'll see that urban hospitals can make money from operations, large rural hospitals make money from operations, but small rural hospitals lose on average around 5.5% from operations. We are considered a small rural hospital. We're 88 beds. Small rural hospital is considered 100 beds or less, okay? Over the last 10 years, we have lost on average 2.4% from operations. Obviously, that's a challenging set of circumstances to run a business and continue to reinvest in your people and your equipment and your facilities, okay? The next slide just kind of gives you an overview of Wyoming hospitals. There's 29 hospitals in Wyoming, 29 general acute care hospitals, I should say. 19 of them are critical access hospitals. 10 of them are prospective payment system hospitals. Critical access hospitals are 25 beds or less and are reimbursed by Medicare at 101% of their Medicare allowable costs, okay? Every hospital in the United States has a cost report, so there's a cost basis for that, especially for the Medicare program. PPS hospitals, of which we are, get paid on a fee basis from the services that we provide. They have what's called a DRG, which is a diagnosis-related grouping. That DRG, so if you have pneumonia, CMS pays you a certain amount for pneumonia, meaning you have to treat this patient in this number of days, and that's what we'll pay you for. So it's within our control to be able to manage those patients most effectively, meaning outcomes of care, and efficiently using the funds that we're given by the Medicare program, okay? We are a PPS hospital. Under the Wyoming state map there, you can see that there are also ownership types. There's not-for-profit hospitals, 501c3. There are county memorial hospitals, which we are a county memorial hospital. There are hospital districts, similar to like a college district or the school district. Those are taxing authorities, okay? And then there are for-profit and private equity hospitals in the state, okay? You guys are well-versed on the districts, and you all know, because I've shared with you in the past, some of the benefits that some of the communities around us get from the valuation of their county, which we don't get. On the next page, Wyoming Hospital's ownership and management. So we are owned and managed locally. So we are owned in combination by the county commissioners that own the property or the county, and the hospital, which owns some of the facilities. So there's a co-ownership there and management locally, meaning that the Board of Trustees who you appoint hires me, we hire a group of people, and that group of people works together to serve our mission, okay? And then there are 19 hospitals that are owned or affiliated with a hospital outside, or a system outside of our state, okay? And a lot of people in Sheridan don't understand that, and we've had a lot of good conversations over the last couple of weeks about those kinds of things. By the way, in the United States, about 68% of community hospitals are system affiliated, only 32% are independent. Okay, so there's a big portion of my presentation I'm going to skip right now, but I'm just going to give you an overview. Of these hospitals right here, these 19 hospitals that own hospitals around the state, a lot of them are large systems. A lot of them are large systems in our region. Some of them are in, other states down in the South and those kinds of things, but some of them are in our region. An example of one is a hospital in Louisville, Kentucky. There's a private equity hospital. It owns the hospitals in Lander and Riverton, okay? And it has made decisions about the healthcare for people in those communities in ways that have really hurt the community in the opinion of the people in the community, so much so that they have built their own hospital in Riverton that they're going to be running. So they'll end up with two hospitals. One is a community hospital, and one is a hospital owned by a private equity company, okay? And there are a multitude of other types of ownership from around the country and regional mergers that have taken place with large entities to our west, to our south, and to the east, okay? There are also hospitals in our state that have affiliation agreements with larger systems like University of Colorado Health. So Cheyenne, Gillette, and Laramie all are affiliated through a management agreement with the University of Colorado Health. In all of those circumstances, the CEOs of those hospitals are employed by the larger health system, University of Colorado Health. The reason those organizations did that was to tap into some of the opportunities that University of Colorado Health offered. In this case, Epic, which is an electronic medical record that University of Colorado Health uses. We as a smaller hospital and other hospitals in our state can't have direct access to Epic, that we're just too small. And so being able to tap into a larger health system, they get access to those things. And they also get access to other things like group purchasing and so on, okay? So the concept that we're talking about is not all too uncommon in our state and in our region. Sorry, I'm shuffling through here. So the next thing you see is this reimagining healthcare. Okay? This is a term that you might hear or may have heard, and people are talking a lot about it. After the pandemic, there were a lot of people who believed that telemedicine and digital care was the way forward, especially for rural healthcare. And so there are a lot of investments. There are several of those larger systems in our region that have invested in the last few years over $1 billion in digital platforms to be able to deliver healthcare services to communities like ours so that patients would have access and so that they would have access to them as well. Okay. Moving on, I'm going to talk about our cost structure real quick. This is one I shared with you. This graph is indicative of healthcare across the United States. This happens to be our experience. However, this is how healthcare works in the United States. It's a broken system. Okay, it's based on cross-subsidization, based on your payer source. Okay, so you can see our blue line going across the middle there. That is our cost basis. That's the cost to do business. All right. So you can see that Medicare pays us 75 cents on the dollar of our cost. Okay, not our charge, but our cost. So critical access hospitals would get paid 101% of their Medicare costs. We get paid around 75 cents on the dollar. For Medicaid, we get paid around 46 cents on the dollar, okay? The only way we make up those losses is on the far left column where you see 146 or $1.46 for every dollar of cost with insurance patients, okay? That's the way healthcare works, okay? I think you're all probably pretty familiar with that. The trigger in this case, though, the hinge point is, what is your payer mix in your community? We have a very old community. It's who we are. This is our demographic. And so we have a lot of Medicare patients. You can see that 50% of our Medicare population is, 50% of our population is Medicare. And that's a challenging set of circumstances, but because before we do anything, all of those patients we care for, we never generate a dollar over our cost to provide care, okay? If you add in the VA, which we get paid about the same by the VA as Medicare and Medicaid, that's 65% of our payers are fixed payers. That means we get what we get from them, and all of it is less than our cost to provide care, okay? So then if you look at commercial is at 29%. So 29% makes up that far left column. So we have to be able to take care of enough commercial patients to offset the losses we have in those other areas, all right? So 10 years ago, our fixed payers were 55%, okay? 10 years ago, our insurance payers were 36%, okay? So that number on the bottom there that says discount ratio, 59%, that's our experience this past year. 59% of our charges now, not our costs, but our charges got written off, meaning we got paid 41 cents for every dollar of charge. 10 years ago, we wrote off 46% and we got paid 54 cents on every dollar. That's a big deal. I can remember back then thinking, how do we manage all of this? And here we are today, and the script has flipped dramatically. And so our payer mix is what tells us how much we're going to be able to generate. And if you look at communities around the state, such as Laramie or Gillette, they're more of a 40-40, so 40% Medicare, 40% insurance, okay? That kind of a payer mix has a dramatic impact on how you get paid, okay? So the next one I'm going to go to is cost structure, and this one is really important, and if we had time, I could go to a map on the internet that shows you specifically. It's CMS website there. You can, if you want to look that up later, you can. But what it tells us is the efficiency of care that we provide utilizing federal funds, okay? Efficiency of care we provide to our county residents using federal funds. This is a metric that CMS put in place over a decade ago around waste, fraud, and abuse, okay? And what it really tells us is how much are we spending on every Medicare patient that we provide care to? And it's based on utilization and consumption, okay? So in the state, we are ranked 23 of 23, and in the country, we're ranked 3,124 of 3,146, okay? Which means that we are one of the most efficient deliverers of healthcare service for the Medicare program in the United States, okay? That's a big deal. It's very meaningful to us because that's how we manage and that's how we run this organization to serve our mission. We take very seriously the resources that people bring to the table for us to care for them, okay? By the way, that average Sheridan County 7,500, state average 9,700, United States average 11,800. Okay, next page talks about consumer perspectives. Obviously, healthcare costs across the country have been going up. Premiums have been going up. Deductibles have been going up. It makes all of us as consumers more active in that process, meaning that we're shopping more for services because the first dollar for healthcare is coming out of our pocket more and more. I can remember when we used to have a $500 deductible and an 80/20 copay. Today, the average Affordable Care Act deductible is around $3,500. A couple of things on that. So people are utilizing their funds to shop because if you have an MRI, you want to choose who's going to provide the best value and the best cost, okay? Best quality and cost, best value. And so we are paying very close attention to that into our future. We need to be positioned to be able to provide the highest level of quality and the best cost for consumers. Now, for those people who can't afford to pay their deductibles, we do, okay? Our community hospital takes out on that deductible because people don't have any funds to pay it. Typically, if that person doesn't pay a deductible, we usually take on the copay as well. Okay, that's a big deal in terms of what we provide for this community. Okay. So in terms of that medical assistance, about $1.2 million last year for medical assistance, around $7 million of bad debt, and around $10 million of subsidized services, meaning services that never generate any funds toward our contribution margin. And those services are extremely needed services in our community. You look at the makeup again of our community, and we have an elderly population. We have 2 rheumatologists in our community. There are 3 rheumatologists in the state of Wyoming, okay? And so we provide outstanding services. Those guys are full every day, okay? If those people in our community didn't have access to rheumatology, they would have to go to Montana or they'd have to go to Cheyenne, okay? That service does not provide a contribution margin for us. Addiction medicine is another one, busy all day. Behavioral health is another one, busy all day. Okay, these are things that exist in our community that we can't ignore or deny. We are there every day to take care of them. Most of us don't see those things. We see it every single day, and we're there to take care of them. Okay, and of course, you all know this very well. We wouldn't be able to do all the things that we do without our foundation. Our foundation provides us with a great deal of support from the community and local foundations to be able to build facilities such as our behavioral health unit. By the way, thank you all so much for all of your support for our behavioral health unit. That was a big deal for us as we were trying to meet the community's needs. So thank you so much for that, that you all. In terms of what's happening all around us, we're paying very close attention to large systems who have a rural health growth strategy, meaning they are interested in going into communities to take care of patients and then bring them into their orbit for care, as well as other types of providers that might come into our community, provide services, specialty services that are high profit type services that take away from our ability to offset all the things that we have to do in order to serve our mission in our community. So our position is that we want to thrive in a regionally competitive environment. We believe that partnerships will give us the things that we need to do to strengthen our position. And that's why we want to pursue some of these things that we're pursuing. Okay. So what are we talking about here? What type of a partnership are we talking about? We've seen a lot of activity going on over the last couple of years in our neighborhood, in our region, with larger hospitals either purchasing other hospitals or merging together to create a larger system. And we're paying very close attention to that. So when we're having our conversations with the community, we show some specific examples of things like acquisition. What is an acquisition? Acquisition is the asset sale of a hospital to another hospital or healthcare system. Okay, that is not something that we're considering. Okay, not even on our radar, not on our mind at all. A merger is the coming together of 2 organizations into one. Okay, so an example of this would be in 2023, Logan Health and Billings Clinic, 2 large systems, relatively large systems in Montana, came together to create one organization. Okay, we'll just call it Billings Clinic. Those organizations independently had around 4,500 employees each. Now they have 9,000 employees under one umbrella. Okay, and that's a merger, okay? And they're still working through that right now. That is not what we're talking about here. That's not something that we're considering or contemplating right now, okay? What we're talking about is an affiliation. And I'm going to get into a little bit about what an affiliation looks like and what that means. Through this affiliation, we remain Sheridan Memorial Hospital. Okay. On the next page, you can see there's a degree of integration. And this chart shows you from low to high degree of integration around the relationships between entities. Okay. On the far right, on the degree of integration is high, and that's an asset sale or purchase. Okay, right next to that is a merger. Okay, so on the far right, you have asset sale and merger. Okay, on the far left, you have affiliation. You have affiliation, collaborative, clinically integrated network, management agreement, management services agreement, and so on. Those in the light blue there can be considered affiliations in different ways, okay? As an example, the management services agreement, that's a relationship that Cheyenne, Laramie, and Gillette all have with the University of Colorado Health, okay? St. John's Healthcare has an affiliation agreement with the University of Utah Healthcare, all for similar reasons, to be able to tap into the scale that the larger entity brings to the table, yet they remain themselves. They're not merged in and they're not sold, okay? If you go to the next page, you can see that I've kind of put those in parentheses so you can see what we're talking about is a collaborative partnership, okay? That's the kind of affiliation that we're talking about, collaborative partnership. So why are we considering this affiliation agreement? We believe that we have an opportunity to do a number of things. One, we think that we can improve the quality of patient care. We think we have an opportunity to bring people together around the collaboration of patients, okay? So really knocking down the rough edges in terms of communication between our organizations to care for patients. Is very important, vital to the healthcare of our community. So those kinds of things around clinical leadership, clinical communication, and organizational leadership, we have a real opportunity to improve patient care. We think that we can improve operational performance. We think that through tapping into economies of scale, such as group purchasing or electronic medical record, gives us the opportunity to reduce overhead costs associated with our operation. An example of this that I think was in the paper is that if we have $50 million a year in supply costs, that Billings Clinic is going to have 10 times that, $500 million a year in supply costs. So their rates that they're able to tap into with the group purchasing that they do are much larger than ours. And we would be able to enjoy the rate that they get once we're able to affect this affiliation. So if we could save, 3% on $50 million, that's a pretty good chunk change. Okay. And then we think that it gives us the ability to strengthen our strategic position. We think that together we'll have an opportunity to grow together, to bring in specialty services, outreach services, and maybe compete at a higher level to bring value to the consumers of Sheridan County. Whereas alone, we might not have the horsepower to do something like that, okay? And it's all about serving our mission and providing value to our consumers, okay? Okay, so on the next page, we really laid out through our initial strategic planning process some key principles that we felt were very important to us, we know are important to the community, and we believe are important to you as well. We want to ensure our mission and values are in alignment with whoever we partner with, okay? So we want to be partners with somebody who believes in the same things that we do and serves a mission within their region. So an example of this is in the mid-90s, a lot of people were still traveling to Billings 3 days a week for dialysis care, okay? There was a lady who was receiving dialysis care up in Billings who was friends with a gentleman by the name of Joe Watt. She went to Joe Watt, and Joe came to us and said, hey, my friend is receiving this care. It's very inconvenient. It's really tough in the winters. Is there anything the hospital can do to set up dialysis care locally for people? And he wrote in a big check okay? And what we decided to do was to reach out to Billings Clinic and create a joint venture, which we did. And that joint venture went until 2015, okay? And we lost on average between $30,000 and $50,000 a year with them as a partner, okay? And we did that because it was the right thing to do for our community. And we believe that keeping people in this community gave us the ability to take care of things locally versus having all these patients have to leave. In 2015, Billings Clinic came to us and said, you know, we're losing too much money on dialysis up in Billings, and we're looking at a company by the name of DCI, Dialysis Clinic Incorporated, and we think that there's an opportunity to work with them and save on supply costs, and we think that you guys could do the same thing, okay? And so separately, we joint ventured with DCI. They with DCI, we with DCI, okay? Somebody that was predatory to Sheridan would not do that, by the way, okay? So they came to us, we now make between $25,000 and $50,000 a year because we were able to decrease the overhead costs associated with provision of dialysis care through basically decreasing supplies and the management of the dialysis unit. Keeping dialysis care in town, we have a fantastic dialysis unit. That has been our experience in working with Billings Clinic over the years, and we believe that they're in alignment with our values and our mission. We want to stay away from any type of a local property tax. We don't believe that this is the way to manage rural healthcare, and we think that sometimes you're not as responsible as you might want to be with other people's money, and we want to stay as far away from that as possible. We want to remain as independent as we can for as long as we can. We want to retain our county memorial hospital status. We want to retain local governance control or board decision control. We want to retain local operating control, local leadership accountability, retain local clinical autonomy, so the local patient-provider relationship, and we want to serve our mission. So the affiliation model that we're looking at is that we'd like to invite Billings Clinic in as a collaborative partner around governance and operations. So basically bring them in for a seat at the table, not only to improve operations, but also to improve quality of care. We want to bring together the best of community leadership and industry expertise to govern and operate our hospital. And we want to build effective governance, leadership, and operational management. Okay, so this next page here shows you our current model, okay? We have a board of county commissioners. The board of county commissioners is responsible for the health and safety of the county, and they cede, or maybe that's not the right word, Clint, they turn over responsibility for that responsibility to an appointed board. That board is a 7-member board, Memorial Hospital of Sheridan County. Memorial Hospital of Sheridan County has a couple of responsibilities. This board hires a chief executive officer, and they also oversee the privileges for our medical staff. So we have an organized medical staff that is subservient to the Memorial Hospital of Sheridan County Board, and they approve their privileges to care for patients within our hospital. And we manage the system of care that we have, and that's how we do it today, okay? I think it's important that we recognize that the community leadership that we've had for our board of trustees over the last 2 decades while I've been in this role has been outstanding. We've had a great relationship with the commission to be able to do the things that we need to do effectively. And as we look at the changing dynamics in healthcare, we need to pay very close attention to how we are most responsive to the environment that we're in. When you have a couple of organizations around you spending $1 billion on a rural health strategy that could impact you, and you don't have that kind of money laying around, it makes it really tough to be able to chart your own course independently without somehow eventually getting rolled up, okay? So what we would be proposing would be a new model. This model would have our Board of County Commissioners, Board of County Commissioners would appoint a 7-member board. Okay, we would refer to them as the Legacy Board. That board then would have responsibility for leasing the asset to a new board, a nonprofit 501c3 board. And this new board would be made up of 7 members. The new board would have 2 classes of membership, a Sheridan class and a Billings Clinic class. And 5 of those Sheridan members, or 5 of the members would be Sheridan members, 2 would be clinic members. Okay, that gives us majority, super majority for the 501c3. Okay, this body would then be responsible for the governance and operations of the organization. They would have the same responsibilities that they have for privileges with the medical staff. And you would have a meeting, a quarterly meeting with the Legacy Board to go over any big issues that are happening with healthcare around finance and quality. And then in terms of the CEO position, the CEO position would be a position that would be an employee of Billings Clinic. We think that that model allows for direct access to strategic leadership within the system that we would be affiliated with. And that's the model that Billings Clinic uses. It's the model the University of Colorado uses, and so on. It's a very common model. The CEO would, however, be completely responsible and accountable to the 501c3 board and the operations of Sheridan Memorial Hospital. Okay. In this case, just like it is today, our foundation would not change in any way. The foundation is a separate 501c3, and all funds toward the foundation would flow to support Sheridan Memorial Hospital. Okay. So one of the big questions that's being asked is why is Billings Clinic interested in something like this? And you know, I've answered the question quite a bit, but I wanted to try and get it from them in their own words. And you know, I think from their perspective, there are a couple of things that they want to be heard on. One is that their affiliation model is really based on local governance and independence. Okay, meaning that when they affiliate with somebody, they don't plaster their brand all over the community and that hospital. That's not what you see in other hospitals around the region necessarily. So keeping local governance control and local identity is very important to Billings Clinic. Sheridan has been a trusted partner to Billings Clinic for a long time. The clinical collaboration across the geography is very important to them. So better coordination of care, especially when subspecialty or critical care for Sheridan patients at the Billings Clinic. Advancing the connection of our electronic health record systems helps provide seamless care transitions back and forth. Additional buying power leading to lower costs, improved population health across our shared geography, and shared efforts around advancements in innovation like IT and artificial intelligence. And I'm just telling you, if you think about that picture I showed you with the girl and the laptop talking to a physician that was in there, over the next 10 years, generationally and in the healthcare industry, we're going to see a huge change in the way that people consume healthcare services. Okay? People are on their phones for everything at a young age today, and those people are going to be coming up into their 20s and 30s, and the way that healthcare services are delivered is going to be on that device. And we need to be able to figure out how we're going to best provide care for our population in that environment. And having a partner in that regard is one of many ways that it's going to benefit us for the future. Okay, I'll wrap it up there. A lot of information. I'm sorry, maybe I took longer than 20 minutes. Chairman, Sir, Commissioner Siddle.
It's okay.
Okay.
I'll forgive you this once.
All right. So I do have a draft of term sheet that we put together. It's a non-binding draft that we've talked about with the Billings Clinic that I'm going to leave with you guys. Okay, that you can review. And I think I'm sure Clint and Diana have had an opportunity to look at that, or I brought a copy for you as well. Thank you. You bet. So I take any questions that you might have.
Questions for Mike?
Mr. Chairman, I guess I'll start it off. I have a couple of questions. I'll start with the proposed affiliation model, specifically the governance. Just a question on the two from Billings. How would those two individuals be appointed?
Yeah, great question. So the initial appointments, by the way, will be made by the current Memorial Hospital of Sheridan County Board. Okay, so the initial appointments for the 5 seats for us would be made by our board. Up to 3 members from our current board can be on that board. And then we would have 2 others at large in the community. Okay, one might be an existing medical staff member. Okay, on the Billings side, Billings Clinic will select 2 people from their organization that would be on there. And then they would be approved with consultation between us and the Billings Clinic folks to create that initial board. After that, there would be a nominating committee on the 501c3, okay? And that nominating committee would take names from either side, okay? So you have the Billings share and you have the Sheridan share. And so each one of those people would bring forward nominations that would be considered by the 501c3 board. And then in consultation with the 2 organizations, the Legacy Board and with the Billings Clinic Board, they would go through that nomination process and be selected.
So a follow-up question to that. I know obviously there's state statute on Wyoming state statute on how the board is created and appointed. Would state statute need to be changed?
No.
For this to occur? Okay.
No, this fits within state statute.
Okay. I guess I very much like the idea of the economy of scale, the affiliation. I don't necessarily, I recognize what you said, that it's common, but I'm not really fond of our executive officer being a Billings Clinic employee instead of Sheridan County, and maybe I'm a little bit more territorial of
No, I
Sheridan.
understand.
Memorial Hospital.
It's a great question. I have one of my, I serve on the American Hospital Association Policy Board. And one of the gentlemen that I serve with, his name, well, it doesn't matter what his name is. Anyway, he's the CEO at Glendive. He's been there 13 years. He grew up in Miles City. And they have an affiliation with Billings Clinic. And he's a Glendive guy. He works for Glendive. Everything he does is for that hospital. And I understand the reservation. I think the practicality of it is there's a lot of strength in being able to have that direct contact with the larger system in my day-to-day workings, knowing that I have that resource, right? Right now, what we do is what we do. There's some, consultation from the outside, and you read, you study, and you try and learn. But what you see in this community is what we do. I think having direct access to those kinds of resources is really important. And at the executive level, I think it's extremely important.
I still am very much of Sheridan County, of course.
Sure.
But the other question.
By the way, to that,
Yeah.
The way forward with that in the term sheet you'll see is that we, the 501c3 board, will go through the process of selecting the CEO. Okay, so I would be the current CEO. When I move on to whatever I move on to in time, the 501c3 board would be responsible for the recruitment of my replacement. And that 501c3 board then would be the one that would make the determination on that in consultation with the Billings Clinic, and would have authorization or approval from the governing board if we haven't switched over to the governing board. It's just going to take some time. It'll take some time for us to move from our current state to this state that I've shown you on the paper. just because there were things that have to happen with CMS tax identification numbers and those kinds of things. But I think the key is that, the local control and governance and oversight all exist within Sheridan, and even at that position.
I think just my concern grows from the idea of, I agree with the board members having two of the board members, but, and when I think of, obviously we have, in our government, we have executive, judicial, and legislative branches, and here it almost seems like you're saying, okay, we'll do legislative and executive, we're gonna give you two of them. And I wanna make sure that it doesn't become Billings, Memorial Hospital, basically. I wanna make sure that we remain Sheridan Memorial Hospital in charge of what's happening here. Yes, we want the benefits that come with an affiliation with Billings, but I don't want to see Billings overshadow Sheridan.
Sure. No, I understand your concern. It's legitimate. I think what I've seen, as I said, what I've seen in practice is nothing like what you're talking about.
And I'd be happy to chat with you a little bit more about it. My other question is actually concerning AI. You talked about that is, and it certainly is, where we see healthcare going. How, do you have some plans in place? My two concerns that come with AI, first of all, loss of relationship with provider. It can become very cold and impersonal when you're talking to a doctor over the computer instead of face to face. So that's one of them. And then the second, it always seems to go to a place where you have the statistical use of resources. I don't want to see it go to a place where AI says, hey, you know what, you are 80 years old, you've got cancer, the resources for you are going to be less than the resources for somebody that's 20 with cancer.
Yeah, great question.
Combat that?
So for us, the way that we combat it is that we lock arms with a strong strategic partner so that we can keep those kinds of things out of our community. Okay, because all around us, people are making large investments to lead with AI into small communities like ours. Okay, we have doctors in our community, we have mid-level providers, and those people have relationships with our patients. And that's the model that we believe is the best model for as long as we can do that and keep out those types of outside interests. Now, we utilize AI in different ways, like we have ambient noise charting, and we have to be very careful with AI because I agree with you. There are so many things that can go wrong with that, especially from the relational perspective in a community like ours. So really, one of the things that we're doing around this partnership is to hold on to the best of what we have relative to those relationships for as long as we can.
Other questions for Mike? Anybody?
No, you answered them already.
Well, maybe you and I should.
I had one, but you answered it, so.
Okay.
Mr. Chairman, I did want to, bringing that up, I did want to say thank you very much for meeting with each of us individually and giving us a heads up and really kind of going through this. It does give us a lot to think about, and I can see where Sheridan Memorial Hospital put a lot of thought into this. I just appreciate that.
Yeah, thank you very much. We have more meetings this week with the public in public forums, and we'll continue to do our best to both educate and answer the questions that people might have and concerns.
Mr. Chairman.
Yeah, go ahead.
May I ask a question? In the structure here, it says the legacy board would be responsible for lease of assets, and then the new governance and operating board is the nonprofit. I just wanted to clarify that this still remains of the county memorial hospital, but under your other ownership types, there is one that says nonprofit 501c3. It's considered private. So I just, for the record, this does remain as a memorial hospital structure.
Correct.
Thank you.
Yep. You bet.
Anybody else? Questions for Mike? Mike, thank you so much for coming.
I will meet it with the term sheet. That's pretty good. Thank you.
Thank you, sir.
Thanks, Mike.
Anyway, we are going to be adjourned at 10:14.